Let's review a challenging case with unexpected findings. The patient is a 24-year-old man with no significant past medical history. He presented with multiple enlarged cervical lymph nodes that had been present for several months. Based on the clinical presentation, lymphoma was strongly suspected. A core biopsy of one of the lymph nodes was performed. On low-power examination, the lymph node is completely replaced by an invasive tumor. The tumor is composed of irregular nests of varying sizes with focal myxoid stroma. In other areas of the biopsy cores, the tumor again forms nests of variable size. At higher magnification, these tumor nests show a distinctive architectural pattern. The tumor cells form rounded nests. Flattened spindle-shaped cells are present at the periphery of many nests. On high power, the tumor cells exhibit marked nuclear pleomorphism, brisk mitotic activity, and numerous apoptotic bodies. The cells have a moderate amount of eosinophilic cytoplasm. Based on morphology alone, the tumor appears to be a high-grade adenocarcinoma. Additional areas show epithelial cells with significant nuclear pleomorphism and brisk mitotic and apoptotic activity. Focal glandular formation is identified. In some fields, glandular structures are seen within a myxoid stromal background. Other areas demonstrate tumor cells with abundant cytoplasm and prominent nucleoli, imparting a hepatoid appearance reminiscent of hepatocellular carcinoma. Some areas show mucinous stoma with tumor cells floating in it. Overall, the morphologic impression at this point is a high-grade malignant epithelial neoplasm, most consistent with adenocarcinoma given the epithelial features and focal glandular differentiation. To further characterize the tumor, immunohistochemical studies were performed. CK7 shows focal but convincing cytoplasmic positivity in tumor cells. CDX2 demonstrates focal but strong nuclear positivity in a subset of tumor cells. GATA3 is diffusely positive in tumor cell nuclei. HepPAR1 shows focal but strong granular cytoplasmic staining in a subset of tumor cells, consistent with true positivity. PAX8 is also positive in a subset of tumor cells. In summary, this is a high-grade malignant epithelial neoplasm that is focally positive for CK7 and expresses multiple lineage markers, including CDX2, GATA3, PAX8, and HepPAR1. The tumor cells are negative for CK20, TTF1, S100, SOX10, OCT34 and CD30. So what is your diagnosis based on these findings? It is a high-grade tumor with unusual immunophenotype. At this point, yolk sac tumor is high on the list of the differential diagnosis. Additional immunostains were performed to confirm the diagnosis. AFP shows diffuse strong positivity in the tumor cells. The tumor is also diffusely positive for CD117. The tumor is also diffusely positive for Sol4 and glypican-3. The final diagnosis is metastatic yolk sac tumor. Yolk sac tumor is a malignant germ cell tumor, most commonly encountered as a component of mixed germ cell tumors. The pure form is rare, accounting for less than 1% of testicular germ cell tumors. Most patients are between 15 and 40 years of age. Elevated serum AFP correlates with yolk sac tumor and is used to monitor treatment response and for post-treatment surveillance. Histopathologically, yolk sac tumor is known for its remarkable morphologic diversity. Common patterns include microcystic/reticular, myxoid, macrocystic, solid, glandular or alveolar, endodermal sinus, perivascular, hepatoid, papillary, sarcomatoid/spindle cell, parietal, and polyvesicular vitelline patterns. This broad spectrum of growth patterns can make diagnosis particularly challenging, especially at extragonadal sites. Interestingly, in this case, we observe rounded tumor nests with flattened spindle cells at the periphery. This architectural pattern has been described in cytology specimens of yolk sac tumor, where tight, rounded epithelial clusters may be partially enveloped by flattened tumor cells. Immunohistochemically, yolk sac tumors are characteristically positive for Sol4, glypican-3, AFP, and pancytokeratin, with approximately 60% of cases expressing CD117. Tumor cells are negative for OCT34 and CD30, which helps distinguish yolk sac tumor from embryonal carcinoma. In addition, yolk sac tumors often express multiple lineage markers, including CDX2, GATA3, TTF1, PAX8, and HepPAR1, a feature that is well illustrated in this case. In summary, This case highlights a metastatic yolk sac tumor presenting in cervical lymph nodes. Yolk sac tumor can be particularly difficult to diagnose in extragonadal locations. When encountering a high-grade epithelial malignancy with diverse growth patterns and expression of multiple lineage markers, yolk sac tumor should be considered. The diagnosis can be confirmed by positivity for SOL4, AFP, and glypican-3, along with negativity for OCT34 and CD30.